Okay, settle in. Welcome to the deep dive. Today, we're grabbing a dense stack of notes and research resources, and we are embarking on a journey into a world of incredibly unique and, frankly, clinically significant bacteria. The Spirochaetes.
That's right.
Think of this as us boiling down the absolute essentials for you, especially you deep in the world of dental studies and, soon to be practicing.
Absolutely. Our mission today is really to unpack these sources, pull out those vital knowledge nuggets, and make sure you walk away with a clear grasp of not just what Spirochaetes are, but why they're so uniquely equipped to cause disease.
And critically, why you, in your future dental career, really need to understand them inside and out.
Exactly.
Because these aren't your typical bacterial spheres or rods you see, well, everywhere else.
Not at all.
They've got this shape that looks like something use in a toolbox. They move in a truly bizarre way, and they have this knack for showing up in places you absolutely need to know about, including, yes, right in your patient's mouth. Let's dive in and unpack this.
Let's do it. Let's start by really getting to know these organisms on a fundamental level. Their most striking feature, the one that immediately sets them apart, is their morphology, their shape.
Yeah, that shape is the first thing that hits you, isn't it? Not round, not rod-shaped. They're these spirals, corkscrews almost.
Exactly. The source material really highlights this as their defining characteristic. They're described as having a distinctive spiral, helical, or, twisted shape. Imagine a very thin, flexible corkscrew.
Right.
They're elongated along their long axis, and that flexibility is also crucial for how they move. We'll get to that.
Thin is definitely the key word there, I noticed. The sources give dimensions that make them sound almost impossibly slender.
They are exceptionally thin, especially when you compare them to many other common bacteria you'll be studying. The source gives the dimensions, typically only about 0.1 to 0.5 micrometers wide.
Tiny.
Very narrow. But they can be quite long, stretching maybe 5 to 20 micrometers in length. So, yeah, long and incredibly narrow.
Okay, so if they're that thin, I'm immediately thinking about trying to see them under a microscope. Does that thinness cause problems for standard lab techniques, like gram staining?
Absolutely. Yeah, their thinness is a major reason they present, diagnostic challenges. It means they stain poorly with the standard gram stain method.
Right, which relies on cell wall thickness.
Exactly. And their thin walls don't pick up the stain well, so a gram stain won't effectively visualize them. They're also described as weakly refractile.
Meaning
Light doesn't bend much as it passes through them, so under a standard bright field microscope, they're just hard to see clearly without using special techniques.
So you can't just rely on the gram stain you use for so many other bugs. If you can't easily see them with a standard light scope or gram stain, what techniques do you need? How do you visualize them?
Good question. The sources are clear that visualizing spirochetes requires specific methods, things designed to enhance their visibility. Dark ground microscopy is a classic one.
How does that work?
Well, light illuminates the specimen from the sides, essentially, so the spirochetes scatter the light and appear brightly lit against a dark background. Makes them pop.
Okay.
Fluorescence microscopy is another powerful method, often using fluorescent antibodies that bind specifically to spirochete parts, making them glow under UV light.
Gotcha.
And it's really vital to remember, as the source notes, some really important species like Treponema pallidum, the syphilis agent, and leptospires are just so thin.
Even thinner.
Yeah, so thin that even standard light microscopy or gram stain is basically useless for seeing them directly. You just won't detect them clearly, if at all, in a typical smear using those methods.
Okay, so recognizing that limitation is step one. Their shape and thinness dictate how we even find them in the lab, but their shape is also intimately connected to their movement, right? Which is maybe even more unique.
Definitely.
This gets into their internal mechanics, doesn't it? Those axial filaments.
Yes. This is where Spirochaetes truly stand apart from, the vast majority of bacteria. Most bacteria that move use external flagella, those whip-like tails sticking out.
Right.
Spirochaetes, though, have their flagella located internally. They're called axial filaments or sometimes endoflagella.
Endo, meaning inside the cell.
Precisely. They're located within the periplasmic space.
Which is?
That's the region between the inner cytoplasmic membrane and the outer membrane, and crucially, they lie underneath the peptidoglycan layer, basically inside the outer sheath of the bacterium.
Wow. That's totally counterintuitive. It's like having the engine running inside the body of the car instead of bolted to the outside.
That's a really good analogy.
Yeah.
The sources indicate there are typically a small number, usually 3 to 5 of these filaments per cell, though it can vary a bit.
And they're not just floating around in there.
No. They're attached, they're fixed to the cell at the extremities, at each end of the spirochete body, and they kind of overlap in the middle.
Okay, so these filaments run along the length inside the space, anchored at the ends. What's their job? Is it just shape, or is it more active?
They have this fascinating dual function. The sources explain they're responsible for both maintaining that characteristic spiral shape and powering their very unique motility.
How?
When these internal filaments rotate within that periplasmic space, they cause the entire outer sheath and the body of the spirochete to twist and flex. It's the rotation of the internal filament that drives the external movement.
So the hidden machinery is directly responsible for the weird way they move. And their movement isn't just a simple forward swim, is it? The source describes a few distinct types.
That's right. Their motility is highly adapted. The sources detail 3 main types of movement you'll see. First, there's flexion and extension.
Like bending.
Exactly, like bending or undulating. They can sort of wave or flex their body. Second, and maybe the most distinctive, is that corkscrew-like rotatory movement.
The drilling motion?
Yes. The spirochete body rotates rapidly around its long axis, like a corkscrew turning, and this rotation propels them forward. And third, there's translatory motion, just moving from point A to point B. While they might glide a bit, the main way they translate is driven by that corkscrew rotation.
Bending, twisting, and boring forward. Okay, why is this specific type of motility powered by internal flagella such a big deal for these bacteria? How does it help them, particularly in causing disease?
Well, it provides a huge advantage, especially in host tissues.
Yeah.
Because the flagella are internal. They're shielded, right?
Yeah.
Protected from the external environment, maybe host antibodies or sticky substances.
Okay, I see.
But even more importantly, that corkscrew rotation lets them move really efficiently through viscous environments.
Right.
Environments that would totally bog down bacteria with external flagella.
Like what kind of environments?
Think about thick mucus layers or the dense connective tissue matrix between cells, or, crucially for you, the complex environment of gingival crevicular fluid in the mouth.
GCF, right. That fluid in the gum crevice.
Exactly. That ability to literally screw their way through dense or sticky stuff is fundamental to their ability to invade tissues and spread within the host.
That makes perfect sense. External flagella would just get tangled up, but internal protected rotation lets them power through. It's a brilliant piece of microbial engineering, really.
It really is.
Okay, so we get their core structure, how they move, but even within this family resemblance, the sources group them into different categories based on variations in that spiral form. What are the main genera we need to know?
Right. Based on morphological differences, particularly how thick they are and how tight their coils are, Spirochaetes are mainly classified into 3 genera important for human health. First, there's Treponema.
Treponema.
These are typically very slender, with tight, regular, often numerous coils. Treponema pallidum, causing syphilis, is the famous one. But also the oral treponemes, which are super relevant to you, fall into this group.
Got it. Slender, tight coils. What's next?
Second is Borrelia. Members of this genus are generally thicker than treponemes, and they have fewer but looser coils.
Okay, thicker, looser coils.
No examples.
Key examples are Borrelia burgdorferi, the cause of Lyme disease, and Borrelia recurrentis, which causes relapsing fever.
Right. And the third?
Third is Leptospira. These are kind of similar in thickness to Borrelia, but they have a very characteristic shape feature. Hooked ends.
Hooked ends.
Yeah, often giving them a shape like a question mark or maybe a shepherd's crook. It's quite distinct.
So even just looking at them, if you have the right microscope setup, you can start to tell them apart based on these features. Tight coils, loose coils, hooked ends. Key visual cues.
Okay, that's a fantastic overview of their basic biology. Now let's pivot from just describing them to the impact they have, because as the sources make really clear, many spirochetes are far from harmless bystanders. They're significant pathogens.
Indeed, yeah. While some spirochetes are just free-living organisms in water or soil, the saprophytes mentioned in the sources, many others, are obligate parasites.
Meaning they absolutely need a host.
Yes, they require a host organism to survive and multiply. And when they infect humans, they can cause a whole spectrum of systemic diseases, some with pretty severe consequences.
Let's quickly touch on some of those major systemic diseases the sources highlight, just to get a sense of the breadth of their impact before we really zoom in on the mouth. The most infamous one is probably Treponema pallidum.
Yes, T. pallidum is the absolute classic example of a pathogenic spirochete causing a devastating systemic disease.
Mm.
Syphilis.
Right.
Sources describe it as sexually transmitted primarily, but emphasize its protean manifestation.
Protein.
Meaning it can affect nearly any organ system in the body. It changes its appearance, its symptoms throughout its different stages if it's left untreated.
Wow.
It's also a strict fastidious parasite. It survives very poorly outside the host. And a critical point for understanding its impact is its ability to cross the placental barrier.
Leading to congenital syphilis.
Exactly, which can cause severe developmental problems or even death in newborns. And while the sources note that its specific virulence factors, the weapons it uses, aren't fully pinned down.
We don't know exactly how it does all the damage.
Not completely, but it's clear that the host's own inflammatory and immune response, and we call it immunopathology, plays a really significant role, especially in the later stages, contributing to the tissue damage and symptoms.
So our own immune system trying to fight it actually makes things worse in some ways later on. Okay, what about the Borrelia species you mentioned, Lyme disease?
Right. The sources highlight two important Borrelia pathogens. First, Borrelia burgdorferi, the agent of Lyme disease. This is tick-borne, starts localized, often with that classic bullseye rash.
Erythema migrans.
That's the one. But it can spread, become a generalized infection. It commonly affects the skin, obviously, but also profoundly impacts the neurological system. The source specifically mentions unilateral facial palsy as an early neurological sign.
Facial paralysis on one side.
Yes. It also affects the heart and the joints, leading to a type of inflammatory arthritis, often in large joints like the knees.
Nasty stuff. And the other Borrelia.
Borrelia recurrentis. This one is transmitted by lice or ticks and causes relapsing fever. It's characterized by these recurring episodes of high fever.
Why relapsing?
Because the bacteria cleverly change their surface antigens, their outer markers, so the immune system has to keep mounting new responses. Hence the cycles of fever.
Wow, that sounds exhausting. Relapsing fever sounds exactly as unpleasant as the name implies. Okay, and finally, the Leptospira species, the ones with the hooks.
Right. Various Leptospira species cause leptospirosis. This typically is zoonotic disease.
Meaning from animals.
Yes, usually transmitted through contact with water or soil, contaminated with animal urine, often getting it through skin abrasions or mucous membranes. It's a systemic infection that can range from mild sort of flu-like symptoms to really severe life-threatening illness affecting multiple organs, particularly the liver and kidneys. Potentially leading to jaundice and renal failure. The severe form is sometimes called Weil's disease.
Okay, so syphilis, Lyme disease, relapsing fever, leptospirosis. These are serious systemic infections caused by different members of the Spirochaetes family. They definitely show the capacity of these organisms to cause widespread disease. But for you, our listener, the dental student, the immediate and probably most frequent encounter with Spirochaetes will likely be right there in the oral cavity. This is where your specific dental knowledge becomes absolutely critical.
This is indeed the pivot point, where the general understanding of Spirochaetes becomes highly specialized for dentistry. Now, you do need to be aware that systemic infections like syphilis can show up with oral lesions.
Which would be highly contagious, I imagine.
Extremely, yes.
Yeah.
But the primary Spirochaetes you'll deal with day to day, or potentially deal with, are the oral treponemes that are part of the normal or sometimes abnormal oral flora.
And the sources introduce us to specific players here, right? Organisms like Treponema denticola and Treponema vincenti. These aren't the syphilis spirochaeta, but they're causing significant problems right in the gingival tissues.
Exactly. They are indigenous to the mouth. And a concept that is absolutely central to understanding their role in dental disease, really highlighted in the source material, is the fusospirochaetal complex.
Fusospirochaetal complex. Okay, break that down.
It's a classic example of a polymicrobial infection, meaning the disease isn't caused by the spirochaetal alone, but through a kind of symbiotic or synergistic relationship with other bacteria.
A complex. So they're working together. What other bacteria are involved in this partnership? Who are they teaming up with?
The sources identify the crucial partners as fusobacteria, particularly species like Fusobacterium nucleatum.
Ah, F. nucleatum. That's a big player in oral biofilms, isn't it? Acts like a bridge.
It is. It's known for co-aggregating with many different species. In this specific complex, the oral Spirochaetes, like T. denticola and T. vincenti, work synergistically with these fusobacteria.
Okay, this microbial tag team. What specific diseases does this particular group cause in the mouth?
The fusospirochetal complex is the primary culprit behind acute necrotizing ulcerative gingivitis, ANUG,
Yeah.
sometimes called trench mouth historically.
That's right. It's a very distinct, painful condition. You see, necrotizing papillae, the gum tissue between the teeth, literally dyes ulceration, this grayish pseudomembrane covering the lesions, significant pain and bleeding.
Sounds awful.
It is. The source also associates this complex with Vincent's angina.
Which is similar but affects.
The tonsils and pharynx. It's essentially the same process, ulcerative gingivostomatitis or oropharyngitis, and these are characteristically anaerobic infections.
Meaning they thrive without oxygen.
Precisely. They love the low oxygen environments often found in deep gum pockets or areas with poor hygiene and tissue breakdown.
And I recall the source mentioning Borrelia vincentii as an older name linked to Vincent's angina. That kind of confirms the historical link, right?
Yeah.
Yes, that's correct. There's a bit of historical classification detail, but it reinforces the consistent observation over time. Spirochaetes involved in this condition. Alongside those fusiform, spindle-shaped bacteria, this synergy means neither group likely causes the full-blown disease as effectively on their own. They need each other.
Okay, so we know which spirochaetes are in the mouth, who they team up with. How do they actually do the damage? Let's talk pathogenic mechanisms, specifically in the mouth. That unique motility must give them an edge here too, right?
It absolutely does. Their characteristic motility, powered by those internal axial filaments, is a key virulence factor right there in the mouth. The sources really emphasize that this movement allows them to navigate and penetrate those highly viscous environments we talked about, specifically gingival crevicular fluid, GCF.
Right, that fluid bathing the tooth gum interface.
Exactly. GCF is full of host proteins, immune cells, other substances. It's much thicker, stickier than just water.
So while other bacteria might get stuck, spirochetes can just corkscrew right through it. What does that motility let them do once they're in that sulcus, that pocket?
Well, it facilitates their ability to invade tissues. The sources highlight their invasive capability. They aren't just sitting on the surface. They can actually penetrate the epithelial lining of the gingival sulcus.
The lining of the gum pocket.
Yes, that delicate sulcular epithelium. And they can move into the underlying gingival connective tissue. This is a crucial point. Their ability to get into the host tissue, to bypass that epithelial barrier, is a major reason they contribute directly to the tissue destruction you see in AE and also in periodontal disease.
They're literally burrowing into the gums. And you mentioned earlier that one of the oral treponemes, Treponema denticola, has a specific power, something particularly relevant to tissue destruction.
Yes, Treponema denticola is specifically singled out in the source material for its significant proteolytic activity.
Okay, proteolytic. Protein breaking. Why is that so damaging in the mouth, in the periodontal tissues?
Well, think about what holds everything together there. Periodontal tissues are rich in structural proteins, especially collagen.
Right, the main component of connective tissue, the periodontal ligament.
Exactly. Collagen forms the scaffold of the gingiva. It forms the periodontal ligament that holds the tooth in its socket. T. denticola produces potent proteases, enzymes that just chew up these proteins.
So it's breaking down the support structures.
Directly. By degrading collagen, it compromises the integrity of the gums, the ligament. This weakening contributes to pocket formation, loss of attachment, eventually tooth mobicity, and loss the hallmarks of advanced periodontal disease.
Wow.
The source even notes T. denticola can degrade dentine, the main tissue of the tooth itself, under the enamel. But its primary impact in periodontitis is really on those soft tissues and supporting structures. This enzymatic power is a critical weapon for T. denticola, and a major reason it's linked so strongly to severe periodontitis.
That's incredibly impactful, breaking down the very scaffolding holding the teeth in place. So let's talk more broadly then about their presence and role in periodontal disease in general. Are spirochetes always there? Do they kick off the disease?
Well, spirochetes, including species like T. denticola, are consistently found in significantly increased numbers in diseased periodontal sites compared to healthy gum pockets.
Their populations explode when disease is present.
Yes, particularly in deeper pockets and in more advanced stages of periodontitis. They are clearly active participants in the ongoing inflammation and destruction happening in those diseased sites.
And they are part of a pretty notorious group in periodontology, right? The red complex.
Yes, precisely. The sources correctly place Treponema denticola as one of the three members of the red complex.
Alongside
Porphyromonas gingivalis and Tannerella forsythia. This trio, this complex, is strongly associated with chronic periodontitis, especially its more severe forms.
Why this group specifically?
They seem to interact synergistically. They work together to cause tissue destruction, promote inflammation, and basically drive the disease progression. Finding these three organisms together in high numbers is a strong indicator of advanced active disease.
So finding Spirochaetes, especially T. denticola, is a definite red flag in periodontal health. Often signifies advanced disease working with these other key pathogens.
It is definitely a marker of disease. However, the source adds a vital nuance here, something really crucial for clinical practice.
Okay.
While their numbers shoot up dramatically with disease, the near presence or even the specific number of Spirochaetes found at one time point isn't considered a perfect predictor of active periodontitis at that exact moment.
Meaning
They are indicators of a disease state, especially later stages, and they absolutely contribute to the ongoing destruction within that complex, messed up microbial community. But their numbers might fluctuate, and they don't perfectly correlate with every single burst of active tissue breakdown. Other factors are also playing a role, both microbial and host factors.
that's an important distinction. They're integral to the pathology, markers of advanced disease, but maybe not the sole trigger for each period of active destruction. Which leads us to a really important concept for you, the listener, the opportunistic nature of these oral spirochetes. The sources mentioned many of them just live in the mouth as commensals, normal residents.
Yes, and this is absolutely fundamental to understanding most oral infections. The mouth hosts this vast, diverse microbiome, and many organisms, including various spirochetes, are just part of the normal, healthy flora. They live there peacefully, causing no harm under typical conditions.
But under certain conditions, they switch hats, they change roles.
Exactly. They become opportunistic pathogens. They seize an opportunity to cause disease when the environment in the mouth changes in their favor or when the host's defenses are weakened. The balance shifts from that peaceful coexistence, that eubiosis, to a state of dysbiosis, where these specific organisms can overgrow and start expressing their harmful potential.
What are the specific conditions, the predisposing factors mentioned in the sources, that create this opportunity for them?
The sources list the classic factors that disrupt the normal oral balance or weaken the host. Things like poor oral hygiene, allowing plaque to build up, mature, and create those anaerobic niches they love.
Makes sense.
Malnutrition, which can impair both general immunity and the health and repair capacity of the oral tissues themselves.
Okay.
And then compromised host immunity more broadly, whether that's due to systemic diseases like uncontrolled diabetes or HIV/AIDS, high levels of stress, or certain medications like immunosuppressants. When these factors are present, the local environment just becomes much more conducive to the proliferation of anaerobes, including that fusospirochaetal complex. It allows them to switch from being quiet residents to active invaders.
This whole concept of opportunistic infection, that's a huge takeaway for dental practice, isn't it? The patient create, or the host's overall ability to manage their own flora.
Absolutely. Yeah. It shifts the focus. It's not just about zapping the bacteria, but also about addressing the underlying conditions that let them get out of hand. Maintaining excellent oral hygiene is fundamental, right?
Right.
Because it directly impacts the microbial environment, keeps oxygen levels higher, reduces the overall bacterial load, stops those anaerobic conditions from developing where these guys thrive.
Right.
And beyond that, recognizing that a patient's systemic health, their nutrition, their stress levels, all these can directly influence their susceptibility to oral infections like ANUG, or how severe their periodontal disease gets. That's crucial for holistic patient care.
So understanding the why behind these infections, that opportunistic switch empowers you to advise patients on prevention, on risk factor management, not just jump in to treat the active disease once it's flared up, which leads us nicely into how these infections are actually diagnosed and treated. You mentioned earlier that lab diagnosis for some Spirochaetes is tricky.
Yes. That difficulty in lab diagnosis is a key point in the sources, particularly the challenge, or sometimes the outright impossibility, of culturing many pathogenic spirochetes using standard lab techniques.
Like T. pallidum.
Exactly. Treponema pallidum, the syphilis agent, cannot be routinely cultured in vitro at all, except maybe in specialized research settings using rabbit testes, which isn't practical clinically. This means you can't typically just send a swab for culture and sensitivity, like you might for many other bacterial infections.
Okay, so if traditional culture is often off the table, how are spirochaetal infections diagnosed? What do we rely on?
Diagnosis generally relies on either directly visualizing the organisms using those special microscopy techniques we discussed.
Garfield fluorescence.
Right. or by detecting the host's immune response to the infection, mainly through blood tests, looking for antibodies serological tests. The specific method really depends heavily on which spirochete you suspect and the clinical picture.
Let's focus on the dental setting first. If you, as a dental professional, suspect A. Nang or Vincent's angina in a patient sitting in your chair, how would you confirm that diagnosis based on the source material?
Okay, for those specific oral infections driven by the fusospirochaetal complex, the source describes a very practical and clinically relevant diagnostic method. Taking a smear from the depth of the lesion, maybe some plaque or exudate, and doing a gram stain.
But wait, you said they stain poorly with gram stain.
They do stain poorly, yes, often appearing faintly gram-negative or gram-variable. But you're not just looking for the spirochaetes in isolation. Crucially, you're looking for the characteristic microscopic picture of the complex.
Ah, the team.
Exactly. You look for the presence of numerous fusiform bacilli, those distinctive spindle-shaped fusobacteria alongside the numerous, often poorly stained spirochaetes. Seeing that specific combination, that fusospirochaetal morphology, on a smear taken from an active, clinically characteristic lesion is strongly indicative of A. neg or Vincent's angina.
So the smear helps confirm the microbial partnership that causes the disease. Got it. The source did mention it's technically possible to culture oral spirochetes in the lab, though?
Yes, it is possible. Research labs can grow oral spirochetes, but it's difficult. It requires very specific enriched media formulated just for them, like oral treponema isolation medium, OTIM. And you need absolutely strict anaerobic conditions, no oxygen allowed.
And even then,
differentiating the various species might involve complex biochemical tests, like looking at fermentation products or using specific antibodies, serology. So, while possible for research, it's definitely not a standard or readily available diagnostic tool for routine clinical practice. The gram stain smear is much more practical for suspected A and G.
Okay, so the smear is the clinically relevant quick check for those acute oral conditions. Now, the source contrasted this with how you diagnose systemic syphilis caused by T. pallidum. Why is it important for you, the dental student, to understand that difference, especially since, as you said, syphilis can cause oral lesions?
Understanding the diagnostic path for syphilis is absolutely critical because, yes, oral lesions, chancres, and primary syphilis, mucus patches, and secondary are common manifestations. You need to be able to recognize these might not be just a simple gum infection and know that the diagnostic approach is completely different from checking for ANUG.
Right.
The source is clear. Because T. pallidum can't be cultured routinely, the diagnosis of systemic syphilis relies heavily on serological tests. Blood tests looking for antibodies.
Serology, okay. The source listed a few acronyms there. VDRL, RPR, FTA, ABS, TPHA. Can you briefly explain what these tests are doing?
Sure. The source mentions two main types, non-treponemal tests and treponemal tests. The non-treponemal tests, like VDRL Venereal Disease Research Laboratory and RPR Rapid Plasma Reagin, are typically used for screening.
Screening?
Yes. They detect antibodies called reagins that are produced often in response to the tissue damage caused by syphilis. But here's the catch. These antibodies aren't specific only to T. pallidum. Other conditions can cause false positives. So they're good for screening large populations and also for monitoring treatment response, because the levels of these antibodies usually go down significantly with successful treatment.
And the other type, treponemal tests.
Treponemal tests, like FTA-ABS fluorescent treponemal antibody absorption and TPHA treponema pallidum hemagglutination assay, detect antibodies that are specific to treponema pallidum itself.
So these confirm the diagnosis?
Exactly. They're used to confirm a positive result from a screening test like RPR or VDRL. An important point is that these treponemal tests usually remain positive for life, even after the infection is cured. So they aren't useful for monitoring treatment success, but they confirm if someone has ever had syphilis.
I see.
The source also mentions you can sometimes use direct microscopy, dark ground microscopy, or direct fluorescent antibody testing, DFATP, on fluid squeezed from an active lesion like an oral chancre to see the spirochetes directly. And PCR is becoming faster for primary syphilis diagnosis too. But serology remains the cornerstone for diagnosing systemic syphilis, especially beyond the earliest stage.
That clarifies the serological picture immensely. So, bottom line for the dental student, if you see a suspicious oral lesion that makes you think, could this be syphilis? Or you're thinking systemic infection, you need to get the patient referred for serology tests. You're not trying to culture it from the mouth or just do a fusospirochaetal smear.
Precisely that. Recognizing the potential for oral signs of systemic disease and knowing the completely different diagnostic pathway is essential. You need to protect yourself, your staff, and get the patient the right diagnosis and treatment.
Okay, that's diagnosis covered. Moving on to treatment. Once these spirochaetal infections are identified or strongly suspected, how are they generally treated, according to the sources? Let's start back in the mouth, a NUG and Vincent's angina.
Right. For those specific oral fusospirochaetal infections, the source provides pretty clear guidance. They are highly sensitive to certain antibiotics, specifically penicillin and metronidazole.
And is there a preferred choice? Anything mentioned in the sources about that?
Yes, metronidazole is often considered the drug of choice for ANU.
Why metronidazole specifically?
Well, it's particularly effective against anaerobic bacteria, which dominate in these infections. And the source points out something interesting. The rapid and often dramatic clinical resolution you see when ANG is treated with metronidazole. That quick improvement provides really strong support for the significant role these anaerobic organisms, both the spirochaetes and their fusobacteria partners, play in causing the disease. They just respond exceptionally well to it.
So metronidazole not only treats the infection effectively, but its success almost serves as a kind of clinical confirmation that you were dealing with that anaerobic complex. Okay. What about the treatment for the major systemic spirochaetal infections? Just a brief overview to show the difference in approach.
Sure. Spirochaetal infections systemically are generally treatable with antimicrobials, but the specific antibiotic, the dose, the duration, it all varies depending on the specific spirochete and the stage or severity of the disease.
So for syphilis, T. pallidum,
penicillin remains the gold standard, the drug of choice. It's highly effective, usually given as injections, sometimes over several weeks, depending on the stage, early versus late syphilis.
What if someone's allergic to penicillin?
Then alternatives like doxycycline or tetracycline are used. Erythromycin is sometimes listed, but can be less reliable.
Okay. And Lyme disease, Borrelia burgdorferi.
Also treated with antibiotics. Options include doxycycline, especially good for early disease, or amoxicillin or ciprofloxacin. For more severe disease, maybe affecting the nervous system or heart, intravenous antibiotics like ceftriaxone might be needed.
And leptospirosis.
Again, antibiotics. Oral doxycycline might be used for milder cases. For more severe illness, intravenous penicillin or ampicillin are options. Alternatives like streptomycin, tetracycline, or erythromycin are also mentioned in some contexts.
So the key takeaway here is that antibiotics are the treatment across the board, but the specific drug, the route, the duration, it all depends entirely on which spirochete is causing the problem and where in the body it is. You absolutely need an accurate diagnosis, or at least a strongly suspected one based on clinical signs and risk factors, to treat effectively.
Precisely. That diagnostic step, whether it's the clinical picture, the smear for ANG, the serology for syphilis, maybe specific tests for Lyme or lepto, is essential for guiding the appropriate antimicrobial therapy. One size definitely does not fit all.
Absolutely. Okay, this has been a really deep dive. We've covered the organisms themselves, their unique corkscrew shape, those internal flagella, the weird motility. We've looked at the serious systemic diseases they cause, syphilis, Lyme. We've focused hard on the specific oral infections they're involved in, like ANU, and their critical role in periodontal disease as part of that red complex. We've navigated the diagnostic challenges, smears versus serology, and talked treatment, like metronidazole for ANU. Let's just bring it back now to the bigger picture for you, the dental professional. Why does all this understanding matter beyond just treating an acute ANU flare-up? The sources touch on systemic connections from the oral cavity that seem crucial for dental practice.
Yes, this is such a vital bridge to understand the mouth-body connection. The oral cavity is definitely not an isolated system. Bacteria from the mouth, and yes, that includes Spirochaetes, have the potential to enter the bloodstream.
Which is known as bacteremia. Transient bacteremia, often.
Correct. The source notes that this temporary presence of bacteria in the blood can occur even during routine daily activities, like toothbrushing or flossing, especially if someone has gingivitis or periodontitis, where that gum lining, the epithelial barrier, is inflamed and leaky.
And it happens even more during dental work.
Yes, it occurs more predictably and often with a higher bacterial load during invasive dental procedures. Things like tooth extractions, periodontal surgery, even sometimes during deep cleaning like scaling and root planing, basically anything that causes bleeding in the mouth.
Okay. And this potential for oral bacteria to get into the bloodstream, this has really significant implications for patients with certain underlying health conditions, right? The source specifically brings up infective endocarditis.
Yes, infective endocarditis, or IE. It's a serious infection of the inner lining of the heart chambers, or more commonly, the heart valves. Now, while certain types of oral streptococci, the viridans group, are the most common culprits for IE originating from the mouth,
They're not the only ones.
no. Other oral bacteria, and potentially including Spirochaetes under the right or maybe wrong circumstances, can contribute. Patients who are particularly susceptible are those with pre-existing heart conditions like artificial heart valves, a previous history of endocarditis, or certain types of congenital heart defects.
How does it happen?
If these oral bacteria enter the bloodstream during that bacteremia and they travel to the heart, they can potentially latch onto these damaged or artificial surfaces, colonize, form vegetations, and cause a really dangerous, potentially life-threatening infection right there on the heart valve.
Wow, this directly informs clinical decision-making in dentistry then, doesn't it? It's precisely why recognizing high-risk patients and taking steps to minimize that bacteremia or its consequences is so critical.
Absolutely. Understanding this potential link between the bugs in the mouth, like Spirochaetes, and serious systemic conditions like infective endocarditis, it just underscores the critical importance of maintaining excellent oral health for all patients, but especially for those with these predisposing systemic conditions.
And for some patients, you actually give antibiotics before dental work.
Yes. For specific, clearly defined, high-risk cardiac patients, current guidelines from bodies like the American Heart Association recommend antibiotic prophylaxis. That means giving a dose of antibiotics before certain invasive dental procedures, specifically to reduce the magnitude and duration of that bacteremia, and therefore minimize the risk of those bacteria seeding onto the heart valves and causing IE.
So knowledge about oral bacteria like spirochetes and their potential to get into the bloodstream isn't just academic microbial trivia. It's directly tied to preventing serious, potentially fatal systemic complications in your patients. It's patient safety.
It highlights the integral role dental health plays in overall patient well-being, absolutely. And the responsibility of the dental professional in recognizing and managing these systemic risks that could originate right there in the mouth.
It seems abundantly clear, then, why a thorough understanding of spirochetes, their weird biology, their specific pathogenic roles in the mouth, the diagnostic hurdles, the treatment strategies, is absolutely essential knowledge for you as a dental student and as a future practitioner.
This knowledge really forms a crucial part of your clinical foundation. It equips you to accurately diagnose common oral microbial infections, like ANU, to understand the complex bacterial picture in periodontal disease, which involves spirochetes as key players, to develop effective treatment plans, including knowing when antibiotics like metronidazole are indicated, and, of course, to implement proper infection control measures in the clinic, because some of these, like the syphilis, spirochete, and oral lesions, are highly transmissible.
And ultimately, it brings it all back to the fundamental importance of preventive dental care, doesn't it? Helping patients maintain a healthy, balanced oral environment is really the first line of defense against these opportunistic organisms getting the upper hand.
Without a doubt. Good oral hygiene practices, taught and reinforced by you, regular professional care, and helping patients manage their systemic risk factors. That's all key to preventing the dysbiosis that allows spirochetes and their detrimental partners to cause disease in the first place.
Okay, we have covered a tremendous amount of ground today. We've gone deep into the unique corkscrew structure and that bizarre internal engine powering their movement. We've seen how this lets them cause serious systemic diseases like syphilis and Lyme disease. We've particularly focused on their specific and critical roles in oral infections like that painful ANG and their contribution to periodontal disease as part of the infamous red complex. We've navigated the challenges of diagnosing them, differentiating between looking for the physospirochaetal complex in an oral smear for ANG versus ordering blood tests, serology for suspected systemic syphilis. And we discussed the effective treatment strategies available, highlighting metronidazole for those acute oral infections.
And importantly, we connected the dots to the broader systemic implications of what happens in the mouth. Understanding how oral Spirochaetes, among other bacteria, can enter the bloodstream bacteremia and potentially contribute to very serious conditions like infective endocarditis, which really emphasizes the need for excellent oral health and, in some cases, antibiotic prophylaxis in vulnerable patients.
So the core takeaway for you, equipping you for your future in dentistry, is that your detailed understanding of these fascinating, clinically very relevant organisms is directly applicable. It's applicable to diagnosing and treating common, impactful oral conditions you will encounter, and it's applicable to appreciating that profound, sometimes life-saving connection between the health of the mouth and the health of the entire body.
This knowledge truly is power in the dental clinic, It informs everything from diagnosis to treatment to prevention.
Now, here is a final thought for you to take away and maybe ponder as you continue your studies. We spent a lot of time understanding how that unique motility of spirochetes, that internal protected corkscrew mechanism, is absolutely fundamental to their ability to invade tissues.
Right.
Right. Boring into gingival connective tissue in the mouth or moving throughout the body in systemic infections. Given how critical this specific mechanism is to their pathogenesis, not just getting around, but actively invading, how might future therapeutic strategies move beyond simply trying to kill the bacteria with our current broad-spectrum antibiotics?
Just a good question.
Could we potentially design treatments that specifically interfere with this unique internal engine? Or maybe block the way it allows them to penetrate tissues? Could understanding that specific motility, that unique feature, open up completely new avenues, new approaches to combating the diseases they cause, both the ones you'll see in the mouth and the systemic ones? Something to think about as you progress in your studies and encounter these remarkable and sometimes troublesome microbes in your practice.
A very compelling direction for future research and therapeutic development indeed. Targeting function rather than just viability.
And with that thought, this deep dive into the intricate world of Spirochaetes comes to a close. Thanks so much for joining us.
Always a pleasure to explore these vital microbiological topics with you, especially for our future colleagues.